I'm Dr. Marla Shapiro, and I have the pleasure of sitting on the Board of Trustees of the International Menopause Society. And for those of you who don't know, the International Menopause Society is responsible for World Menopause Day, which is October 18th. So joining me today is the President of the International Menopause Society, who I know does not need an introduction, but will you introduce yourself to our audience?
Thank you, Marla. My name is Nick Panay. I am indeed President of the International Menopause Society. I'm a consultant gynecologist from London, working at Queen Charlotte's and Chelsea hospitals, and also Imperial College London. And it's a great pleasure to be with you here today.
Well, firstly, Nick is one of the co-authors of the White Paper, and we have a white paper that comes out on World Menopause today, and there's a handout that comes along with it that's actually so informative. For the past 2 decades, if not longer, there has been so much controversy about the use of menopausal hormone therapy, and it's become so polarized that I think we've lost in all of this conversation and yes, no, good, bad, and all of the things that have been so confusing about menopausal hormone therapy, really what we're meant to be talking about, which is really what this is for, who this is for. And one of the brilliant things about this paper is that it really gives us a framework with which we can examine menopause hormone therapy in terms of the evidence, as opposed to a lot of the background noise and feelings, if I will, that have come out in this polarizing conversation. So firstly, let's talk about who is menopausal hormone therapy for?
So menopause hormone therapy is for women suffering with symptoms associated with the menopause transition. Those typical symptoms are hot flushes, sweats, vaginal dryness, irritation, pain on intercourse, occasional urinary symptoms, and there's also good evidence that it will improve bone density as well. Whilst there is some evidence for its preventive benefits for cardiovascular disease, it is not currently an indication for protection against heart disease. And there's also been quite a lot of controversy as to whether it protects or does not for dementia. At the moment, this is not an indication, and that area requires more research.
Okay, so then let's talk about who menopausal therapy is not for.
So it should not be regarded as a fountain or an elixir of youth. Whilst we would all love to use something which turns the clock back, so to speak, I think the most important thing to focus on is optimizing our well-being through various strategies, and hormone therapy may be used to improve quality of life and some aspects of well-being, but it should not be regarded as an elixir of youth. It does have potential risks as well as benefits.
So there are a group of women, though, even if they have intractable symptoms of menopause, still will not qualify for menopausal hormone therapy. So women with blood clots, pre-existing stroke, cardiovascular disease, there are some medical reasons for which we would say, no, we would not want to initiate this.
Absolutely right. And I think whenever we're making a decision whether to prescribe hormone therapy or not, or better still to recommend it or not, we have to take those potential risks into account, which we determined by taking a good medical history from that individual. And ultimately what we're trying to do, Marla, is personalize or individualize therapy so that we can maximize benefits and minimize any side effects and risks.
So the first most important message, I think, for prescribers and women who are listening to this is that there is a who that this applies to, whereas the notion that there is nothing safe or effective for the relief of intractable symptoms of menopause.
Indeed. We have to think very carefully about the person in front of us. Not all menopause requires treatment. I'd like to put that out there from the very outset. Many women go through the menopause and don't have any symptoms or have minimal symptoms that can be managed through lifestyle, diet, exercise, stopping smoking, reducing alcohol consumption, etc., etc. And then there are other approaches, talking therapies, complementary therapies, which should be evidence-based if they're going to be used, and non-hormonal pharmacological options if indicated. And whenever we're thinking about what's right for that individual, we need to be thinking about prescribing or recommending from the whole treatment armamentarium, but underpinned by optimizing lifestyle, diet, and exercise.
And always lifestyle is going to come first, but to reassure our prescribers and women as well that this really is the gold standard for the treatment of intractable hot flashes, night sweats, the vasomotor symptoms that you've mentioned, that there is a large group of women who somehow have believed that it isn't safe or effective, and we really do want to change the conversation, at least open up that there is a who that this applies to.
Yes, I mean, I think it's really important that we carefully weigh up the balance of pros and cons, benefits and risks. Hormone therapy is still regarded as the most effective treatment currently for vasomotor symptoms, and also we mustn't forget that topical hormone therapy is highly effective for local symptoms as well, and I think this is an area which is often neglected. Other areas which I think are important and also often neglected are women with premature or early menopause, where we do look at the potential for preventive as well as therapeutic benefits from using hormone therapy. There is good evidence that women in this young age group, young menopause if you like, have a higher risk of osteoporosis, cardiovascular disease, and cognitive problems, which can potentially be mitigated through the use of hormone therapy. So the who is the crux, really. Right. It's about individualizing.
Okay, so let's go on to the what, because that's the next W that I want to talk about. So let's answer the what when it comes to menopausal hormone therapy.
So when we talk about hormone therapy, there are various options. If we can break it down into the typical components of hormone therapy, which are estrogen, progesterone, and also I'm going to talk a little bit about testosterone as well. So as far as estrogen, there are various different types of estrogen available, but in terms of symptom relief, they are pretty much or sort of equally effective with some variations. In terms of the dosing, we have to use the minimum fully effective doses. And if we do think about increasing the dose because there are persistent symptoms, then we have to be careful about monitoring that individual's response.
So I'm going to interrupt you there to talk about minimum and fully effective, because you've put those two words together, which is so critical for, I think, women to hear and prescribers to hear, that often everybody focuses on the minimum. Let's use the least, but if it's not effective, that minimum is not appropriate for them. So, you know, the fact that although we think about using the lowest dose may not always be the appropriate dose for the woman sitting in front of us.
Absolutely, and this is why I emphasize that it should be the fully effective minimum dosage. We can start at lower doses and then titrate upwards depending on the requirements of that individual. If we have a younger woman, she may need to start on higher doses to begin with, because it's more physiological for a 20, 30-year-old who's gone through premature ovarian insufficiency, which is the technical term for premature menopause, if you like. But for women going through the menopause at the usual age, which is late 40s, early 50s, we can start with lower doses, but then it's really important to achieve doses that are fully effective for her symptoms.
So often, you know, for healthcare providers or for women, because they look to their friends to see what their friends might be using, I always say, don't look to the right, don't look to the left, please look at me, so that we can have this individualized conversation. The different sort of what's of the routes, whether it's you take it by mouth or you put it on your skin or you wear a patch. Speak to us a little bit about the differences in these formulations and whether or not that truly matters as far as the woman is concerned.
So over the last few years, there has been a move, if you like, towards more transdermal use of hormone therapy. And the rationale for that is that if you deliver the estrogen through the skin rather than taking it orally, that it avoids the first pass liver effect. So it doesn't have as much of an effect on clotting factors or an effect on blood pressure. But I think there has been too much pressure for women to use transdermal, so patches, gels, sprays, etc., when if they don't have any medical complications, any medical risks, and they would prefer to take a tablet, it's perfectly safe for them to do so. And I think we should be giving them the choice of doing that. On the other hand, if a woman has a history of high blood pressure, or if she has obesity, which could potentially increase the risk of clots, this is where estrogen through the skin may be safer for her. But ultimately, Marla, what really matters is about choice, isn't it?
Yes.
There's no point in me saying use a tablet or use a patch if that individual doesn't want to use a tablet or a patch. They have to be comfortable with the method that we recommend to them.
So we've identified the WHO, the woman with hot flashes, night sweats, and tractable symptoms. The fact that among the what, there are different doses, routes, formulations, that you're really talking about a shared decision making between the provider and the woman who's listening to what's available to see what they would like best. So we've got the WHO, we've got the what, and the fact that there's different doses, different routes, different formulations, but essentially they're all going to be aimed at the treatment of the same thing. Okay, so let's talk about the when, because we have women who will be symptomatic but still be having cycling in what we call perimenopause, or not quite at menopause. Then we have women in menopause. So let's talk about the when to initiate.
So it's well recognized that symptoms such as hot flushes, sweats, sleep disturbances can start before the periods have stopped.
Right.
In what we call the perimenopause, a time when perhaps the periods may be erratic but are still coming. And it is more tricky to treat women when they do still have a cycle. We do try to treat. I have to emphasize that this is off-label because hormone therapy, if you speak conventionally about the license or the label, is for women who are in the late perimenopause or in the menopause when the period has stopped. So the menopause is 1 year after the final menstrual period.
And just to interrupt for our women listening and our practitioners, this isn't an abrupt, you're here and then you're there. This is a transition over time, only defined by no cycles for a year when you're menopausal. But everything else that comes before can be variable in terms of its length or symptoms.
Indeed. So the length of the period may vary. The interval between the periods can also vary. And one of the things we have to be careful about is when we counsel women about possibly using hormone therapy in the perimenopause, is that they may continue to get erratic bleeding, even though we may put them onto a cyclic regimen which should give them a regular bleed. And I think it's all in the counseling process, because if you don't provide that information to the woman, then she will feel concerned that if her bleeding is erratic in the first 3 to 6 months, that there may be a problem. So I think it's really important that we state that there may be some erratic bleeding to begin with, but this should settle down in due course. The other thing that can happen in the perimenopause, which can, if you like, throw a spanner in the works, is that sometimes the ovaries can produce more estrogen, and sometimes the symptoms which occur are not due to menopause. They may be due to overestrogenization, so symptoms like nausea, breast tenderness, fluid retention. But those symptoms will usually pass because ultimately estrogen levels will drop.
So when we're thinking about the when, in terms of introducing estrogen, whether it's, as you say, by a pill or through the skin, however that is, there are women who have a uterus and then women who have lost a uterus for some reason. Those women will require different management to protect the uterus. Talk to me about that.
So when giving estrogen in women with a uterus, it's important to give progestogen, which is either natural progesterone or a synthetic type of progesterone, which protects the lining of the uterus, which prevents the lining from thickening and prevents bleeding problems. If a woman has had a hysterectomy, then she can have estrogen without the progestogen, but there are certain circumstances where we would consider giving progestogen. For instance, in a woman with a history of endometriosis that has surgery in order to prevent the endometriosis from recurring.
Okay, so again, for women who are listening to this, who may be wondering what we're talking about, basically what we're saying is we're individualizing your therapy based on if you have a uterus, if you don't have a uterus, and if you've had other intercurrent medical situations that make your situation unique. Now, there are other medications that are fixed combinations that don't necessarily use a progesterone or a progestin. So we've got other medications available depending on where you live in the world. So talk to me about that. So things like Tibolone or fixed combinations of Duaviv, particular medications that are out there.
Yes, there are these preparations which, if you like, mimic the effect of hormones. So Tibolone is a compound which mimics estrogenic, progestogenic, and also some androgenic, so testosterone-type properties. Duaviv is a combination of estrogen with a selective estrogen receptor modulator. That's a long terminology, but essentially it's another non-hormonal way of preventing the uterine lining from thickening. So these are useful options for women who want to achieve particularly a no-bleed regimen and are typically prescribed at least 1 year after the final menstrual period.
Okay, so suffice it for women who are listening as opposed to our prescribers, there are lots of options that are available for you when you meet the who and the what and the when.
Absolutely.
For estrogen therapy.
As far as I'm concerned, the bigger the toolkit, the wider the armamentarium, the more easily we can individualize treatment according to that individual's wishes and also medical requirements.
And before we leave the when and move on to some of the other W's, we've talked about when to initiate, typically ideally menopause, but leading up to the menopause is a particular situation that will be a conversation between you and your healthcare provider. The notion of the when to stop. There's always been this sort of notion that shortest dose, shortest period of time, that I've spent years trying to dispel that phrase should disappear, because as you've mentioned, it's all about being individualized. But the notion of a fixed stop date for this type of therapy?
That should be confined to the history books.
Gone.
Absolutely.
We've banished that term.
The view that I have and that of the menopause societies globally is that we should not put arbitrary limits on duration of usage, that it should be individualized, and there should be at least an annual review of the pros and cons of continuing with that particular method, reviewing that method, and whether the pros outweigh the cons to continue.
Okay, so before we leave the when, because we've done the who, the what, and the when, you mentioned testosterone, and we did not have that conversation. And that for, depending on if you're North American or if you're European or wherever you may be, that may be a different conversation globally in each of the countries. But testosterone in general and the menopause.
Well, first of all, it's important to emphasize that testosterone is a female hormone. But it doesn't necessarily always require replacement. And we determine whether replacement may be useful by following what we call a biopsychosocial approach. So we look at various aspects of a woman's history as to why she might benefit from testosterone. But the primary indication for it currently is what we call hypoactive sexual desire disorder, which is essentially distressing low libido. Right. So if that individual has libido which is low and it's distressing either her or the couple, then in that instance we need to consider what may be the cause. Now, there may be biological causes. It may be due to testosterone deficiency, but there may be other causes as well. There may be psychological causes, there may be social causes, there may be cultural reasons, and there may be pharmacological reasons as well. For instance, antidepressants often do lead to low libido.
Yeah, a side effect of an unintended side effect.
And the other thing to emphasize is that just because libido is low does not necessarily mean that it's distressing. Right. An individual or a couple may be perfectly happy for there to be low libido.
Mm-hmm. Okay, so now let's move on to we've done the who, the what, the when. We have addressed the why a little bit. Let's talk about the where.
I think this is a really important thing to talk about, because whatever we sit here and talk about in terms of the treatment options, there are still many parts of the world, particularly in low and middle income countries, where hormone therapy and alternative options are difficult to access and may not even be available at all. So we have to cut our cloth to measure. What does that mean? That means manage menopause according to what is realistically available in that particular part of the world. And that's why it's really important that we think holistically about how we manage menopause, that we can try and manage symptoms with lifestyle, with diet, with exercise, with optimizing other aspects of health. And then when we're recommending treatment options, ensuring that those options are available in those particular countries. That is not to say that we should not strive as the International Menopause Society and our big council of affiliated menopause societies, which are 64 societies and regions all around the world, to influence governments and departments of health in a positive way to provide as many menopause treatment options as possible. Because I always say, if you invest a little bit of money now into menopause, you can save a lot of money in the future. And we're living at a time, this decade of healthy aging, the UN decade of healthy aging, when we know that over 1 billion women will soon be in a menopausal age group. And if we start to make a difference about their quality of life and long-term health, that can have not only profound effects on that individual, but also economically as well on the country's productivity and as a whole. And as you know, there's been a lot of interest recently about menopause in the workplace. And the healthier women are in the workplace, the more productive they will be.
Without a doubt. So we've looked at who, what, when, where, why. But part of what I do want you to comment on, because depending on what part of the world that you are from, when we have a lot of safe and effective regulated preparations that are on the market, and you yourself have talked about transdermal through the skin, oral, gels, we've got lots of different preparations of hormones that are safe and effective. We see this area in different parts of the globe where there's so-called custom compounding. So firstly, define for people what we mean by this notion of custom compounding.
Well, this notion regarding compounded preparations, I suppose arose particularly after the findings from certain studies that perhaps exaggerated the risks of conventional hormone therapy. And the notion was that if you customize hormone therapy and give more natural products, that you could potentially reduce the risks of hormone therapy.
And I'm going to put the natural in parentheses here, because sometimes that word natural will imply to women that it is definitely safer and without side effects. And I do want you to dispel that natural does not necessarily mean that.
What I mean by natural is that the hormones that are used precisely mimic the hormones that would have been naturally produced by the human ovary.
Body identical, I call them.
Yes, I prefer to call them body rather than bioidentical, because bioidentical is quite a commercial term.
Right.
Body identical basically describes what they do, what they are, which is basically replicants, if you like, of the hormones produced by the human ovary. Now, there is some evidence from studies that giving human type of estrogen and progesterone potentially may have some metabolic and breast benefits. But that doesn't mean to say that the individual has to go to a specialist pharmacy to obtain that.
Right.
There are perfectly available in many countries licensed options which can be used, which will replicate those hormones and provide body identical hormone therapy or body similar hormone therapy for women wishing to seek those types of hormones.
So lots of options that have been studied, that are pharmacological grade, where we know the doses, we know the safety, we know the efficacy. The notion something of making something as a custom, where we don't necessarily have regulation of what's going in there and that the products are not the same from time to time, has its own sets of issues associated with it. So we really do want you as a woman and you as a prescriber to think about what is the safest and most effective on-label, available, studied, government-approved medications? Totally.
The treatment options that we prescribe for our patients have to go through rigorous testing for effectiveness and safety. There have to be published data on the levels of these hormones within the bloodstream, so-called pharmacokinetics, and also studies to indicate what the clinical response is. Often these data are very few or absent for these compounded products. So I don't really see the need to switch to something which is less evidence-based for effectiveness and safety. As you say, there may be batch-to-batch variation in terms of purity and quality as well, when you can get regulated options that will have the same actions and the same benefits with a much greater portfolio of information regarding safety.
So I think the brilliant part for me in reading the white paper was the fact that we had a skeleton, if you will, on which to base some of these really critical concepts: the who, the what, the where, the when, the why, which you have so elegantly gone through. I want to point out to our practitioners throughout the world that available on the International Menopause Society homepage is the white paper, which is really published for physicians, practitioners, nurse practitioners, all of our partners in delivering healthcare to menopausal women. And for women around the world, we also have this wonderful pamphlet that's available for you that really brings it down for women at a level that we can understand as women what menopause and menopause hormone therapy is about. Because I think the important part of this white paper was to remove all the background noise that's polarized this conversation and bring it down to science, information, and evidence, if you will. So the final one after the who, what, when, where, why is often we talk about the how. And I think the how will be an individualized conversation between you as a woman and your healthcare provider to decide what is the best route and treatment that's safe and effective. So Nick, before I let you go, addressing World Menopause Day 2024, what was your goal in this choice of being one of the primary editors and writers responsible for this topic for October 18th, 2024?
So my goal was to provide clarity as to how menopause can and should be managed. And I think it's really important that the narrative which is out there is as balanced as possible. And I believe, as you've said, that there is polarization of views which can potentially lead to disempowerment of an individual. And what we should be doing is empowering women to make an individualized choice that's right for them, so that they have the information which is specific to them to balance up the pros and cons of what approach they use for managing their menopause. Be it lifestyle, diet, exercise, be it menopause hormone therapy, be it non-hormonal options. No one menopause transition is the same. And I hope that the paper that we have produced through the International Menopause Society, my colleagues on the executive and the board were extremely helpful in providing this balanced narrative, will support women and also their healthcare providers in providing individualized management options. And as you've said, we've published in the white paper itself some of the science and the data associated with these recommendations, and more practical approaches and treatment options in the materials that we've provided for women. So hopefully something for everyone.
So on this World Menopause Day, October 18th, we hope that you'll take a look at the white paper as practitioners, and as women, you'll look at the handbook and the toolkit that we've provided, so you'll know what we are talking about when we talk about all the W's, the who, the what, the where, the when, the why, and that you understand that this is a conversation based in science and evidence, and that as an individual provider and an individual recipient of healthcare, you have a customized program based in science and evidence to do healthy aging in the menopausal years.
Absolutely.
Thank you so much for joining us today.
Thank you, Marla.